Good morning, everyone. Today, we will be speaking about arterial line insertions in the intensive care units and in the operation theatre. This is the measurement of the arterial pressure by a device inserted into the artery. This enables us to measure the arterial pressure in a beat to beat and a continuous fashion. It also gives us some idea on the cardiac contractility based on the waveforms and gives a good idea about the volume status of the patient based on the systolic pressure variation and the pulse pressure variation. Some of the indications of measuring the arterial pressure would be increasing requirements of inotropes, surgeries involving major blood loss, or the need for frequent arterial blood gas sampling. The common sites used to measure the arterial pressure include the radial artery, which is the most common site. The advantage of it being it's not an end artery. The other frequent sites used are femoral, brachial, and the dorsalis pedis artery. These equations every one of us would be very familiar with. The pulse pressure being the difference between the systolic and the diastolic pressure, and the mean arterial pressure being the diastolic plus one third of the pulse pressure. Most of the monitors also display the mean arterial pressure in a continuous fashion. Now, coming to some of the debates which has been going on, what are the problems with a non-invasive measurement? Why do we really require invasive pressure monitoring? The NIBP, which is based on the oscillometry, is inaccurate, especially in situations of hypotension and arrhythmia. And the accuracy is dependent largely on a properly sized cuff. The cuff should be at least 2/3 of the upper arm or 40% of the mid-arm circumference. The other most frequent problem is use of heparin in the flush bag. Initially, this was used very frequently, but nowadays most of the centers, including ours, have stopped using heparin in the flush bag because there is no proved incidence of increased arterial line thrombosis when only normal saline is used. And using heparin also increases the chance of heparin-induced thrombocytopenia. What are the things that you would require when you plan to do an arterial line? Would be 2% chlorhexidine solution, a 20 gauge cannula, local anesthetic solution, sterile drapes, transducer system connected and flushed. Topics not covered in this video include zeroing, leveling and calibration of the arterial line, which would be discussed in another video in detail later. Commonly used methods are transfixation method, which is the most commonly used method. Others being Seldinger technique, ultrasound guided arterial line cannulation, and a cut down, which is generally not very frequently used unless or until when there is a dire need of it. Now this will be a video demonstration of the arterial line insertion. First is most important step is positioning. As you can see, the performer is seeing to that he is able to insinuate two fingers beneath the extension. If you keep the extension very close to the wrist, then the artery gets stretched, and even if you had punctured the artery, you would not be knowing that you have punctured the artery. So it's always better to be able to insinuate two fingers between the extension and the wrist. The other is proper fixation with plasters so that the hand is very stable and does not slip. CDC recommends usage of 2% chlorhexidine solution for all these line insertions. Now, as we can see, initially the area is cleaned properly using a sterile solution, and then we use a 2% chlorhexidine solution. Some of the troubleshootings which we generally see when we insert an arterial line would be puncturing the artery but not able to cannulate the artery. Now generally we use the counter puncture method, which is shown in this video also, wherein the artery is punctured at an angle and then we decrease the angle further a bit and go some more in. Now, as all of you would know, the cannula has a puncturing needle and a cannula proper. There is a small millimeter difference between these two, and our aim in any of these arterial line insertions would be that the needle and the cannula should be completely within the artery for a proper and successful cannulation. Now, when we puncture the artery, we see a backflow of blood within the hub of the cannula, and that shows that the artery has been punctured. Now we can see that local is being infiltrated, which is a very important step in arterial line cannulation to prevent arterial vasospasm. And then we can see that the artery is being palpated and then puncture is being made. As you can see, the performer is using a 60-degree angle between the skin and the artery, and once he's entered the artery, we further decrease the angle and go further in. Now we have lost the artery, means we are not seeing the blood continuously flowing. Hence he has pulled out the needle a bit and we are pulling the needle and the artery. Now we can see that blood has filled the cannula and it's continuously filling. So this will be a successful cannulation. Now the next step is connecting it to the transducer and checking whether we are getting a proper waveform. Before that we'll have to zero the arterial line and then we are able to see that we've got a successful waveform. Troubleshootings in arterial line cannulation and the ways we would overcome it, we will be discussing in another video. Thanks a lot for watching and please do subscribe our channel for further updates and videos. Thank you.